Good afternoon. May I say a particular good afternoon to those of you who are behind the glass. This is a rather strange experience for me, as well as I'm sure for you. But a very warm welcome from me. I'm Carol Black. I chair the board, the Centre for Ageing Better. And as I think you all know, we are here to launch the State of Ageing 2023, our flagship report. This year, we've been able to paint a more detailed picture of ageing in England than we've ever seen before. It comes close on the heels of the Chief Medical Officer's excellent report on improving the quality of life in adult later years. Our publication uses the latest data, including from Census 2021, and covers a range of topics: demographics, employment, homes, health and well-being, society, and financial security. We have particularly focused on the increasing diversity of our older population and the very significant disparities between how people from different ethnic backgrounds experience older age. Alongside analysis of national data sets, we've also been speaking to older people to hear their views and learn from their experiences. And I'm really delighted that today we have with us members of our Expert by Experience network who are sitting here in the front 2 rows, and representatives of 2 community organisations, Weighing Society and the Third Age Partnership, with whom we've been working to produce the State of Ageing this year. Their insights and experiences have added so much to the richness of our work over the past year, and we are enormously grateful and thankful to you all for your time and generosity in sharing your experiences with us. We are, of course, especially pleased to be joined by Professor Sir Michael Marmot, who will give tonight's keynote speech. Michael is missing his grandson's birthday party, and that's, I'm very, very grateful to him that he's come, but I'm not sure that his grandson will be very pleased. Sir Michael really needs no introduction. His seminal work on health inequalities is known around the world. He will speak to us about inequalities in our experiences of later life and how we can take a place-based approach to support older people to live well. We will then have time for questions and discussions, which will be chaired by Dr. Carol Easton, Ageing Better's Chief Executive, and then please join us for the reception immediately afterwards. But first, let me introduce Dr. Aideen Young, Senior Evidence Manager at the Centre for Ageing Better, who will begin this evening's proceedings with an overview of the incredibly rich data in our report. Aideen.
Thank you, Carol. So I don't think there's any more preamble needed from me. I think Carol said, speak up. Is that good? Can you hear me? Yeah, all good, thank you. No more preamble needed from me except to say it's great to be here. A lot of us have worked very hard, so it's fantastic to be able to present to you some of the key findings from the report this evening. First of all, a tiny little bit of context just about what is all this talk about ageing, why has it become so very important. It's because a huge population shift is underway, and I'm sure you all know about this. We currently have 21 million people aged 60 and over. That's nearly 2 in 5 of the population. We have over 10 million people 65 and over. That's 1 in 5 in the population. And if you look at the bars, what you've got here is the population by census year back to 1981. We have had a 50% increase in the number of people 65 and over since 1981. We have 3 times more people aged 85 and older than we did in 1981, and these trends are set to continue. There's two reasons for that. One, we have the 1960s baby boomers making their way up the population, getting older, and there's a huge number of those. Someone born in 1964 at the very height of that baby boom is 59 today, so they're going into that older cohort. And the other thing that's going on that changes the population structure is the decline in births, and therefore the number of people in the younger age groups is actually going down. So at the moment, the percentage of people 65 and over in the population is 1 in 5. In 40 years' time, it will be a quarter. So that's a big change. And the other big thing that's happening in the population is that it is becoming more diverse, ethnically and in other ways also. In the 2021 census, 1.1 million people 60 and over come from Black, Asian and minority ethnic backgrounds. Now, that's not an awful lot, but it is an 80% increase in the last 10 years. And it's the same goes for the LGBTQ plus community. It's a very much a much greater number going into later life. So we have a big shift also in how we live. There's a big change in the number of people, a big increase in the number of people who are never married, who have never had any children, the number of people living alone. So later life is looking different and will continue to do so for quite some time, from now on, really. And when we talked about the changing profile of our ageing population, our experts by experience who are here with us told us, of course, that this is a reason to celebrate, and obviously it is. But of course, there's another side to the coin too, and that's because the negative impact of discrimination and structural inequality accumulates across the life course. So that as our older population becomes more diverse, there's the possibility, likelihood, that we will have many more people in that older population who are poor and in poor health. And in addition, there's the possibility that racism and sexism experienced across the life course are now compounded by ageism. So there is a chance that without action, an increasingly diverse older population may mean more older people in poverty, in poor health, as well as greater inequality within this group. So as for poverty, poverty has been decreasing over a very long period of time, but since 2012, 2013, there's been a bit of an uptick. You can see it sort of started creeping up again, so that at the present day, we have almost 20%, that's 1 in 5 pensioners living in relative poverty. Now, there are two major drivers of pensioner poverty. One is declining income from private pensions, particularly caused by people with no private pension at all, as well as the inadequacy of our state pension. And certain groups are most affected by this: disabled people, carers, women, self-employed people, and people from some ethnic minority backgrounds. And this is because of inequality arising from low pay, fragmented work histories, part-time hours, and discrimination. People with Pakistani and Bangladeshi backgrounds experience the highest rates of poverty. In fact, a quarter of people aged 50 and over from these ethnic groups live in deep poverty. That's 50% below the official breadline, which is really rather scandalous. The second major driver of pensioner poverty is the cost of housing. Now, the poorest pensioners spend proportionately more on housing than do than higher income pensioners, even after accounting for housing benefit. And this is because poorer pensioners are more likely to rent their homes, while the better off pensioners are more likely to own theirs. Older private renters spend half of their income on rent. So while at the bottom line there are people, the dark purple one you can see there, those are the owner-occupiers, pension-age adults who are owner-occupiers, and it's showing the change over time. So at the present day, 13% of that group, people who are owner-occupiers, are in relative poverty, compared to 38% of pension-age adults who rent privately. So it's a really very huge difference. There's another big issue to do with private renting, and that is about the prevalence of non-decency in this sector. A high proportion of privately rented homes are non-decent. That is to say, they are a serious threat to the health and well-being of the occupants. There are 3.5 million non-decent homes in England, and half of those are headed by someone 55 and over, a third by someone 65 and over. And in every age group, what you see here is you've got different age groups along the bottom. The tenure type is the different coloured bars. The green bar is the private rented sector. So what you're seeing here is in those 3 bars to the left, people 54 and below, 55 to 64, and 65 to 74. Homes headed by someone 74 or under, approximately a quarter of them are non-decent. But privately rented homes headed by someone 75 or over, it goes up to 4 in 10. 40% of those homes are non-decent. And this matters because the number of older private renters is at an all-time high. In fact, the number of people renting privately aged 50 and over doubled from 1 to 2 million in the last 20 years. And certain groups are more impacted by this than others. The census has allowed us to see what the tenure of different ethnic groups looks like. And we know that a quarter of people from Black African backgrounds rent privately, compared with just a tenth, 1 in 10 overall. So poor quality homes, non-decent homes, are not just associated with poverty, as I showed in the previous slide, but they also are a huge contributor to poor health, with first-year treatment costs to the NHS of £1.4 billion per year. And talking about health, this chart shows from the census the percentage of women with bad or very bad, who self-report bad or very bad health, by age. Age groups are along the bottom, and I hope you can, maybe you can't see, that might be quite difficult, and a selection of ethnic groups up the side. I hope you can see it. And I'm going to highlight a couple of things here because it's really very striking. A couple of things, that the rates of bad self or very bad health for different ethnic groups start to diverge from one another at very young ages, which is quite extraordinary, as young as well. I mean, there's differences between these lines even at the age of 16 to 24. And then in accordance with the fact that that the disadvantage accumulates across the life course, they continue to diverge, and they get further and further apart. So that's one thing I wanted to point out. The second is that 22%. That says 22%, almost a quarter of women from Bangladeshi backgrounds, aged 50 to 64, are in bad or very bad health. And that's the same proportion as white British women 85 and over. It's like a 35-year difference. I'd also just quickly like to point out that the rate of bad or very bad health for Black African women is not dissimilar to that of white British women. And that is quite different to that, say, of Black Caribbean women and to the BAME category as a whole. And I highlight this here to sort of emphasize the limitations of using a amorphous, undifferentiated BAME category, which doesn't allow you to see the differences between these different ethnic groups, which are really very different. And as regards health also, the other thing I was going to say about this is that self-rated health also varies by geography. The best is in the southeast, the worst is in the northeast, and we also find that twice as many people aged 50 to 64 living in the least deprived areas are in good health. Twice as many are in good health in the least deprived areas as in the most deprived areas. Being in work, in good work, which provides financial security, purpose, meaning, and social connections, is one of the wider determinants of health, as are homes. But poor health is contributing to increasing levels of economic inactivity. This shows over time, 2019 to 2022. We've got different age groups. The dark blue bar, the big bar, is people aged 50 to 64. It's the number of people who are economically inactive in each of these years due to long-term sickness. And we can see that the largest number is in that age group, and we can see that it has increased over time. Now, in the 2 decades up to the pandemic, up to 2020, the number of people 50 to 64 in the workforce in employment rose by over 3 million, and there are 1 in 3 workers in the UK are 50 or older. But during the pandemic, we saw a decline, a dip in employment rates, it happened across all age groups, but was most pronounced for people aged 50 to 64. And since the pandemic, employment rates have rebounded for all age groups except for the 50 to 64-year age group. And sickness, injury, or disability is the reason most commonly given by people in this age group for having fallen out of the workforce, followed by retirement. However, there's a very important difference because it's the lowest earners who've fallen out of the workforce because of sickness, and it's the highest earners who have left work in order to retire by choice. And now we find that many workers in their 50s and 60s want to go back to work for financial reasons, probably stimulated by the cost of living crisis, but are struggling to do so because of caring responsibilities, a lack of flexible working, age discrimination in hiring practices, and employment support services that do not meet their needs. And this is a scenario that will inevitably increase pensioner poverty even more. So to come full circle, poverty reduction was historically achieved through a combination of rising employment for working age adults and benefits and tax credits. And so interventions that address worklessness are vital for the productivity of individual companies, to fill job vacancies and boost the economy, for individuals for their well-being, and to reduce pensioner poverty levels. And if we don't address this, pensioner poverty levels are really going to be a problem for quite some time to come. So thank you very much. That is the conclusion.
We're going to have a short film. We'll give it 1 more minute, and then otherwise we'll do it the other way. Aha, is it working?
Yep, just got to check volume. It's coming.
Discourteously, you are ignored, and I think it's because of the biasness of society.
They've known since the 1950s, when the present older people were born, that there was going to be a problem when we all retired. Nobody complained when we were all working and putting loads of taxes into the system, but now we're all retiring, we are suddenly perceived in some quarters as a burden on society.
Everyone thinks that we've got resources at our age, and actually I have to say I am fortunate in that when my mum died we paid off our mortgage. Having housing security is a huge relief of emotion. There's one less thing that you don't have to find every month.
Not all old people have got money. They've not all got money. They've paid the taxes, they've paid their insurances, but if some old people have not been in pension schemes, then, they're just struggling on the pension.
I have to say, especially in this country, out of all the countries in Western Europe, I think you've got a lowest chance of aging well.
If you talk to somebody in their 80s or 90s and you discover that actually a lot of them have lived long, fascinating lives, they've done loads and loads of stuff, achieved amazing things in their life, and yet by the time they get to that age, they're just seen as this sort of amorphous mass of old people that are some kind of problem to society because they're a drain on the national resources. So they're not seen as individuals.
There's a lot of improvement needed for older people.
If we treat older people properly, younger people will also get treated properly, and various diverse communities will also get equally treated properly. So I think it is important that we as society change.
It's time that we're not working in silos. It's time that housing is not working on its own, or health, or social care.
I am not the politician, so I don't know whether I am. I hope that there is a change. I hope that they listen to what people said.
It's not just about putting a bit of money in here or a bit of an initiative in there, but seeing the big picture. And the big picture should be people have an equal right to a decent life, and it doesn't matter who.
For many people today, living longer is not just a hope, but an expectation. Many more of us are living into our 70s, 80s, 90s, and beyond. But experiences of aging are becoming more unequal. While the state of aging suggests that for many people in England, aging could get worse, this is not inevitable. This is why it's crucial that we act now to plan for our aging population and ensure that the needs of older people are represented in policy making.
Thank you, and thank you very much to people for participating in that really powerful film. So you'll have an opportunity to meet some of the participants a little bit later, I hope, but really enormous thanks for doing that. So I'm Carol Easton. I am the Chief Executive at the Centre for Ageing Better, and I have the privilege of introducing to you tonight Professor Sir Michael Marmot. I certainly, throughout my career, heard about Michael. He is an expert on health inequalities. He's a professor of epidemiology and public health at UCL. He's the director of the Institute of Health Equity, and fairness seems to be in his blood. And I've been doing a bit of Googling this morning to read a bit more about you, Michael. And some of the articles that I've read really demonstrate to me your huge commitment and passion for tackling inequalities in this country. And I know you're held in extremely high esteem for the work that you've done. And your view that, you know, your health shouldn't be determined by where you live, that there is a level of unfairness in this country that we must do something about, is completely a driver for all the work that you do. So I was thrilled that you were agreed to speak today, and really looking forward to hearing what you have to say. So if you could welcome Sir Michael, please.
We live in the best of all possible worlds. Do you believe that? An optimist has been defined as somebody who thinks the present organization of society is the best that could possibly be. A pessimist fears that that may very well be the case. I think we should look at the evidence. The opening line of my book, The Health Gap, I'm a bit busy at the moment. In fact, our colleague from Manchester is sitting with a copy of my book, The Health Gap, on her lap. The opening line was, why treat people and send them back to the conditions that made them sick? Particularly at older ages, when we think about inequalities, we think a great deal about inequalities in access to the health care system. Very important. But the key drivers of health inequalities are the conditions that make people sick. In my 2010 Marmot Review, Fair Society, Healthy Lives, and again in the 10 years on review, we had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, employment and working conditions. Number 4, very relevant to what we've just been shown, having at least the minimum income necessary to lead a healthy life. Number 5, again, highly relevant to what we've just been shown, healthy and sustainable places in which to live and work. And number 6, taking a social determinants approach to prevention. In light of the pandemic, and it should have been there all along, we've added a 7th, tackle racism, discrimination, and their consequences. And the 8th, in a way, has always been there, deal with the climate crisis and health equity together. I said, let's look at the evidence. Do we really live in the best of all possible worlds? Well, this is what's happened to life expectancy over time. It was increasing about 1 year every 4 years for women and for men. And that went on for most of the 20th century. 2 world wars, but apart from that, 1 year every 4 years. In 2010, there was a break in the curve, and the rate of improvement slowed dramatically and just about ground to a halt. Now, if you agree with the proposition that health tells us a great deal about our society, all the work that I've been doing over the last several decades suggests that so close is the link between social determinants of health and health that if health's not improving, it means society is not improving. And if health inequalities are getting bigger, it means inequalities in society are getting bigger. And much of that, of course, was what happened to older people when the mortality rate for older people went up. Went up. I just said that as if it was normal. It's not. That's not what we expect. We expect health to get better all the time. And after 2010, the rate of improvement slowed. And look what happened by region. If you classify people by where they live, and classify where they live by level of deprivation, what you see is a social gradient. The greater the deprivation, the shorter the life expectancy. Now, compare the Northeast and London. You can't see that. For the least deprived, 10%, the differences between London and the Northeast are small. If you're rich, it doesn't much matter where you live. The greater the deprivation, the greater the disadvantage of living in the Northeast compared with London. Or to put it the other way, the social gradient is steeper in the Northeast than it is in London. Now look at what happened over time. Look at London, the solid bar, 2016-18, the dotted bar, 2010-12. Life expectancy improved in each decile. There's still a social gradient, but it improved in each decile. In the Northeast, life expectancy went down for the poorest 10%. It didn't improve for the next decile, the next. For the bottom 60%, the most deprived 60% of the population, outside London, life expectancy did not improve over that decade. And the expectation is that it would improve year on year. That's what's supposed to happen. That's what did happen through the whole of the 20th century. And in 2010, it stopped happening. And the disadvantage of living in the Northeast, the Northwest, got bigger. Wow. And we're not doing well. This is healthy life expectancy. If you can make it out on the slide, the red dot is the UK. And that, what a funny dot right down the bottom, is the US. So what this is looking at is healthy life expectancy at birth in 2000 along the x-axis, and in 2019 on the y-axis. And what you can see, and the dotted line is the equivalence. In general, like Japan, right out there at the top, was healthiest in 2000, and it was healthiest in 2019. But look, the US is way below the line. It got less healthy. And the UK didn't look very good in 2000 and got a bit worse by 2019. So when we published those data showing that life expectancy had stopped improving, one of the arguments was, well, it's got to stop improving sometime. Can't go on forever. Well, look at other countries. Our life expectancy, and crucially, healthy life expectancy, is shorter in the UK than in most comparison countries, except the United States. And we've had a decade of austerity, a decade plus of austerity. The government elected in 2009-10. I hasten to add, you may not believe it, but I'm not party political. I just look at the data. I'm just a nerd who looks at the numbers. So the government that was elected in 2010 said, austerity, it's a moral imperative. We've got to live within our means. That's what they said. And they did it, by golly. Public sector expenditure in 2009-10 was 42% of GDP. That went down year on year. So by the end of the decade, that 42% had become 35%. Then came the pandemic. The Chancellor, now here's a quiz. Can you remember which of the 7 chancellors we've had since 2016 happened to be in place at the beginning of the pandemic? 7 chancellors since 2016. Are we in a mess or are we in a mess? I'll give you a clue. He's now the Prime Minister. The Chancellor said, when the pandemic hit, whatever it takes. Oh, wow. When the global financial crisis hit, we didn't hear whatever it takes. We heard, we've got to live within our means. We'll become like Greece. We've got to cut everything. But faced with another economic crisis associated with the pandemic, the Chancellor said, whatever it takes. Oh my gosh. You mean in 2010, it was a political choice, not an economic necessity. They could have done otherwise, but chose not to. The damage that was done to the country in the decade, the 13 years after 2010, was as the result of a political choice, not an economic necessity. Good heavens. We said when the pandemic hit that it would expose the underlying inequalities in society and amplify them. Whoops. And look at this. Life expectancy for men and women living in the most deprived areas of England fell significantly between 2018 to 20 and the previous triennium. It fell for the bottom 40% of the whole of England. In fact, for men, it didn't go up at all in those 3 years, 2018 to 20, compared with the previous triennium. For women, it fell in the bottom 40%. And in general, the greater the deprivation, the greater the fall. So inequalities are getting bigger. And not shown here, healthy life expectancy is getting worse. Women in the poorest decile can expect to live a third of their shorter lives with ill health. The Alzheimer's Research Society just produced a report just about to be published or just published, and this was one of the papers that they reviewed, looking at deprivation and dementia. We all know somebody with dementia. I've written a commentary and said it's the great shadow that hangs over all of us. But like everything to do with health, that shadow is cast unequally. In general, the greater the deprivation, the higher the risk of dementia. Less deprivation off to the right there, more deprivation off to the left. And the less the deprivation, the lower the dementia risk. And look at ethnicity in the middle one, particularly high in Black and South Asian. Higher deprivation, higher risk of fractures. So fragility in general, fracture of the radius and ulna, fracture of the hip, greater deprivation, greater likelihood of fracture of the hip and of the spine. So we think these things that come with aging are somehow inevitable. They aren't. They're associated with deprivation. Aging is not some kind of destiny that means ill health. The nature of the ill health and lack of function that goes with aging is socially determined. Look at this. Let me put it in context. People like me used to say, we're a rich country, and as a rich country, we should be able to afford to do everything that's needed. In fact, that's not quite true. Look at people in the 90th centile of household disposable income, adjusting for purchasing power. The dark blue is the United States, and here's Norway, that's Switzerland. And the red is the UK. So compare Norway and the UK, our richest 10% are roughly as rich as the richest 10% in Norway, a bit poorer, quite a bit poorer than the richest 10% in the US and Switzerland. Now look at the median, the 50th centile. People in the middle in the UK are much poorer than the middle in Norway. People in the middle and poorer than Switzerland. Now look at the bottom 10%. People in the 10th centile in the UK are much poorer than in Norway and Switzerland. The US is as bad as us. It is very bad to be poor in the UK. The bottom 10% have less income than in Slovenia. In fact, we're a poor country with some rich people. And that is very telling for what it means to grow older in the UK. And now look at regions. This is GDP per capita, adjusting for purchasing power. In the UK, London is the richest region. Take London out, and the GDP, the national average, goes down by 14%. In Germany, if you take the richest region out, Munich, doesn't change the GDP. In the Netherlands, take out Amsterdam, GDP goes down by about 4%. In the US, by about 2%. If you take London out of the UK, we are as poor as Mississippi, the poorest US state. That's where we are. Outside London, in the UK, this country is as poor as Mississippi, the poorest American state. Did you hear anything in the autumn statement that addressed this issue? There was a levelling up white paper, which I read, 4 missions, 12 objectives. We can talk about it, but it was the amount of money put into levelling up was derisory, insulting. And if you're on benefits, forget it. The Joseph Rowntree Foundation and the Trussell Trust calculated how much it costs to meet the necessities of life, the essentials, food, shelter, heating, and the like. And this is what it costs, and this is what you get on universal credit. Universal credit gives about 70% of the cost of the necessities. In other words, if you're on universal credit, we guarantee you'll get sick. That's how we've done it. We produced a report a year ago on fuel poverty, cold homes, and health inequalities. 3 components of fuel poverty: household income, the current cost of energy, and the energy efficiency of a home. Look at this. If you're in the poorest 10% of household income in France, you spend about 6% of your household income on energy. Sorry, in the richest 10% in France. If you're in the richest 10% in the UK, you spend about 6% of your disposable income on energy. If you're in the poorest 10% in France, you spend 10% of your household income on energy. If you're in the poorest 10% in the UK, you spend 18%. That gap between the richest and the poorest in the amount of household income spent on energy is bigger in the UK than in any other European country. This, I repeat, is not a good place to be poor. And one of the consequences of that is you have to do without some essentials, like heating your home. And we have very high excess winter deaths, higher in the UK than in the Nordic countries, much colder countries, but because of fuel poverty. And look what's been happening to excess winter deaths. Now, you'll hear, if you read the reaction to the autumn statement, that we're heading for the highest tax levels we've ever had. Okay, let's look at tax burden. The Office for Budget Responsibility calculates that our tax burden is 34% of GDP. In the EU14, it's 40%. Now, it's true that the OBR predicts, because of freezing of the thresholds, that 34% over the next 4 or 5 years will go up to 37%. That's still less than the EU14. We're a low-tax country. And the tax burden was lowered today in the autumn statement. So sorry, nurses, sorry, doctors, sorry, other workers in the public sector, you can't be paid more because we've got to cut taxes. So you've got to work at substandard wages. That's all pretty grim. Why am I not grim? I'll tell you why I'm not grim. 40+ places in the UK have declared themselves marmot places. Coventry, a marmot city. Greater Manchester, Cheshire and Merseyside, Lancashire and Cumbria, Luton, a marmot town, Waltham Forest, Gwent, and on we go. Leeds declared itself a marmot city. And we've started to get business involved. Legal & General, a big insurance company and a financial institution, approached us, my colleagues and I, at the Institute of Health Equity, and said, we want to know what we can do in our day job that would improve health and reduce health inequalities. And we produced a report, and we said 3 things: provide good quality work, pay, benefits, conditions, and the like, pay everybody a real living wage. Goods and services. If you're the tobacco industry, we can't work with you because what you do damages health. If you're the food industry, what you do is vital for health. You could be bad for health or good for health. We'd like you to move in the good direction. And the third is the wider impact on the society. So I've presented quite a bit of bad news, a little bit of good news. Let me finish with a quote from a Welshman. To be truly radical is to make hope possible rather than despair convincing. Thank you.
Goodness, that was fantastic. Thank you so much. And so many, triggered so many thoughts and so many questions. We are going to allow you all to ask questions. So start thinking. There will be a roving mic. Is it going to be possible to get the mic behind the glass as well? Yes, good. I've got someone waving her arm at me, so that's perfect. But why don't we start? Have you both got a mic? If you press, there should be another one, maybe. So you have one each. If you press the button, make it green, people will be able to hear you. So let's start. Michael, you said you weren't political. I'm not sure whether people are going to believe you, first of all. But let me ask you both, if there was one thing while people are thinking and formulating their questions, what's the one thing you, going to push you to be political, would like to see national government do to reduce inequalities in experiences of ageing? So what's kind of, if I had to force you on one thing, what would it be?
One thing, read my book.
Okay. Excellent, all right.
But if you tried me to get me to be a bit more specific, I would say on day one, screen every policy initiative for its likely impact on the equity of health and well-being. Mm-hmm. If you'd done that in 2010, you wouldn't say, oh, we'll got to cut everything or we'll look like Greece. You'd say, what's the likely impact of the changes we're making on equity, the fair distribution of health and well-being? And then I've got 8 specific recommendations that would underpin it, but that's where I'd start.
Okay, thank you. Aideen, what would you say?
Well, and I think one of our recommendations is, of course, that we would have a bill of health with health built into all policies, and with a particular eye on the most vulnerable, the most disenfranchised, and ethnic minorities. I think for us, all of the things that are, all of our recommendations, if we talk about wanting a good later life for older people, but we are focused on those who are most in need. So really, everything that we do ought to reduce inequalities. Ultimately, that's what will happen if those things are effective. And of course, things that we recommend are so disparate. They're absolutely across the piece. There's things about, about work and employment and homes and, all sorts of things. But I think the overarching one that perhaps we could capture everything else is our Commissioner for Older People and Ageing, because all the other things that we want to see happen could be sort of incorporated into the portfolio of such a person who would pressure government, maintain pressure across different administrations, because that simply isn't happening. So that ought to, if it worked and we were able to then to implement all those other things that were all of our other recommendations, that would have the effect of reducing inequalities.
Thank you. Right, so have we got questions from the audience? Do put your hand up emphatically so that I can see you all the way over there. Okay, we have a gentleman whose name I happen to know over here, Paul McGarry from Manchester. Could you give him the mic, please? But do introduce yourself, Paul.
Yeah, hi, colleagues. My name's Paul McGarry. I work for Greater Manchester Combined Authority. My question is, there hasn't been a strategy on healthy ageing or ageing in England for certainly since 2010, and I think without a national approach to ageing, as opposed just to health inequalities, we're missing out on a lot. So my question really is, why do you think that there hasn't been a national approach to ageing, and specifically what can public health agencies do about inequalities in later life rather than just earlier in the life course?
Well, I've stopped asking the question of why the politicians in Westminster do or don't do what they do. I don't know what they tell themselves. I can see what they do, but I don't know why they do it. I mean, why pursue policies to make poor people poorer? I can't credit that. I just don't understand what goes through somebody's mind, what they tell themselves when they rest their head on the pillow. Maybe they can't rest their head on the pillow. But why would you pursue policies to make poor people poorer? Why would you pursue policies that predictably will stop improvement in the health of the population? So to ask, why have you not got a national ageing strategy, I can't answer the question why. What I have done, I've been asked, do you have a theory of change? Yeah, I've got a theory of change. I knock on a door, and if it doesn't open, I don't bang my head against the door. I find a door that might open. And so the reason we've been working with cities and regions is because they want to take action. And yes, of course, there should be a national strategy for ageing better, just as there should be one for early childhood. But there isn't. Child poverty's gone up. We spend less on early childhood than most OECD countries. So we don't do it. But there's real interest in Greater Manchester, in Cheshire and Merseyside, and Coventry, and Leeds, and all these places we're working with, to do it. And so my hope is that enough cities and regions will take the action that's needed, that in the end, the politicians in Westminster will follow. They'll have to. They'll get left behind otherwise. So I'm hugely encouraged. In fact, in Greater Manchester, it was the City of Manchester that took up my report and produced their own report for a fairer Manchester and their plans of what they want to achieve in the next 5 years, which includes healthier older people, better conditions for older life. So we do need a national strategy, but in the meantime, let's do it where the politicians really do want to act, which is at the city, regional, district level.
Thank you. More questions? I can see Jabir at the back there, please, behind the glass. Who's got the mic? Oh, you've got to pass it over. I thought we could give you another one if it helps. I'm sure Eddie won't mind sharing. I hope it's not a religious divide. I'm not sure how this room is used normally.
Thank you.
Speak, Jabir. Is it on?
Yes, it is. Thank you, Cara. David Cameron's been much in the news of late, and I'm loath to remind us about some of the things he's done in the past, but one of the things he did do was try and start a debate around happiness and the role of government in promoting happiness. And he was ridiculed and laughed at, and very soon decided not to do anything about it. But I do wonder whether perhaps we do need to open ourselves up to ridicule and bring some other ideas to the fore. For example, should we be changing the mission of the Treasury? Should we be saying that actually the real thing we need to achieve here is that the Treasury needs to focus on inequality? And that's what it needs to set out to do, rather than spending all its time thinking about economic growth and so on. It's inequality that's the thing that's killing us all, and perhaps that's what its mission should be.
Really interesting. I'm going to maybe take one or two more before I ask you both to respond. There's a woman over here, please. In a pink jacket. I sound like Fiona Bruce now, don't I? Pink jacket.
Please.
Thank you. Hello, I'm Philippa Mariani and I'm from Think Ahead, which is an organisation that attracts and recruits people into mental health social work who perhaps wouldn't have otherwise thought about social work as a career option. And all of the determinants, the social determinants of physical health that we've been talking about today absolutely resonate in mental health as well. We know that if you live in poverty, we know that if you experience discrimination, we know that if you can't get into good, well-paid employment that keeps you above the poverty line, you are more likely to suffer mental ill health. And I think that although we do train people who sit in older people's mental health teams, I think that it's a very, very underdeveloped area. I think that there is there's a lot of ignorance and a lot of disassociation with older people and their mental health. It's almost, if you're older, this is what you can expect for your life from here on in, and we're not going to look at your mental health. So how can we make sure that mental health has an equal parity of esteem in any strategies that we develop for older people?
So we're going to, should we change the remit of our government departments, and what can we do to improve the addressing of mental health in the agenda as well? Do you want to respond to those?
The American historian Gary Gerstle published a book, I think earlier this year, called The Rise and Fall of the Neoliberal Order. And essentially he tracked from the election of Franklin Delano Roosevelt in 1932, started government in 1933, with the New Deal. And he said the New Deal essentially lasted until Ronald Reagan in the US and Margaret Thatcher in the UK. And there was a recognition. I was reading about Harold Macmillan not long ago. In terms of some of his policies, I think he'd look like a Lib Dem today. I mean, the politics has moved so far. He was somebody who believed in Europe, he believed in higher education, he believed in public housing. I mean, all this stuff that's gone completely off the agenda. And Gary Gerstle's book was called The Rise and Fall of Neoliberalism. So this new era that was ushered in 1980, I mean, Americans are looking back at Ronald Reagan and saying he looked relatively benign compared with what the prospect of a second Trump term. And so this era that said everything can be left to the market, inequality, who cares, no public purpose, no such thing. You remember John Kenneth Galbraith of Private Affluence, Public Squalor. So that's where we've been for the last 40-odd years. Now, the nice thing about what Gerstle wrote is it was the rise and fall. And I would say what I've been reporting on over the last 12 or 15 years of what's happened to health, getting worse. For the bottom 60% of people are not improving in the Northeast and the Northwest. So what's been happening to health means our current settlement isn't working. It really is not working. And so putting inequality in the central place. I mean, we have, if you look at income inequality, we're the second most unequal rich country. It was most unequal in Europe and the second most unequal after the United States. I mean, when I say rich country, if you want real inequality, go to Brazil and sub-Saharan Africa, and you get real inequality. But among the rich countries, we have the second biggest after the US. And income and increasingly wealth inequality. And we're saying, yeah, that'll do. And leveling up, it was never taken seriously. All right, I'll give you a figure, may I? That when Germany leveled up And this comes from the government's Levelling Up white paper. When Germany levelled up, in other words, when the former German Democratic Republic was integrated into the Federal Republic of Germany, they spent, I translated it into pounds, they spent about 70 billion pounds a year. And guess what? The life expectancy gap narrowed. The disadvantage of being in the East compared with the West got less. In fact, just about closed for women. They spent 70 billion pounds a year. In the Levelling Up white paper, the budget was 4.8 billion over 4 years, 1.2 billion a year, compared with 70 billion. Did you hear anything in the autumn statement about levelling up? Nothing. In fact, have you heard anything since the government's white paper on levelling up about funds for levelling up? Nothing. We're not doing it. We don't care, obviously, about the inequalities, the regional inequalities. And I showed you, outside London, we are as poor as Mississippi. We really need a new settlement, and grappling with inequality has got to be at the heart of it.
Adrian, before I move on to a question here, so if someone could start bringing a mic down, please.
Well, I was...
Did you want to say anything about
I was
this?
just going to say that I've been interested in the in how the inequality gap is bad for everyone, and that we don't really talk about that, and that then we might get an awful lot more attention about the inequality gap if the people at the top felt that it was actually detrimental to them also. So we talk about the effect of it on the people at the bottom, but the size, the magnitude of that gap brings the average down for the population. I believe that's true, isn't it? So that is a compelling piece of information about inequality. As for mental health, we do have some charts on mental health and state of aging. We know that people in 50s and 60s have the greatest levels of anxiety. We also know it's one of the major reasons for people falling out of work. We've been talking about it too because we know that, you might know we're launching an anti-ageism campaign in January. And it's one of the areas that we know, for example, that older people are much less likely to get talking therapies for mental health issues and more likely to be prescribed medications. So that's something we've been really, that we really are looking at, and we want to address ageism in the medical treatment of older people.
Thank you. Yes, I think word ageism hasn't been used till just now, I think. Or no, you used it in your presentation, but also I think in response to some of the questions about why don't things happen in this country. Certainly that would be one of our hypotheses, that actually not looking at poverty and inequalities and attitudes about older people all come together. Would you like to ask your question now?
I'm Pauline Smith. I'm from Aging Better. I'm one of the so-called experts because we're older. Unlike most people in this room, I spent 30 years working outside the UK, the last 20 of which were in the Netherlands. And I came back to the UK about 15 years ago, so just before the current bunch of scallywags got elected. And what struck me when I came back, and I left in 76, which was not exactly an economic high point, and we'd just gone into the EU, was how poor the country was then, and since then, how much poorer it's got. And looking at your chart, the last place I lived in was Alkmaar, which you had got as being poor. Believe me, Alkmaar is not poor. And in the time that I've been away, the Dutch have invested in different things than we have here. in affordable housing for their young people, in proper infrastructure. Believe it or not, they have no potholes in the whole country. In a combined infrastructure with their rail system, their bus system and everything else. The other thing that's very noticeable when I was last back there, which was 3 or 4 years ago, and I'm 75 now, was that people who were 10 years older than me were fitter than I am now. And I'm sorry to go on so long. My question is this, because the Dutch have a concept called the polder mentality, where they work together. This country has been split with divisions because of Brexit and everything else. And like many of my counterparts who are here as experts, we all try to work to make things better. So my question to you is it possible to implement something like that, and maybe as a first step, as a society, actually insulate our homes properly?
Thank you, Pauline. So, really interesting comparison, and then the issue about homes and the quality of the homes, which you touched on in terms of cold and electricity.
Well, in my 2010 review, I coined the concept, the phrase, proportionate universalism. I said that the classic Anglo-Saxon approach to social policy is you target the worst off, means tested benefits. A more Nordic or Netherlandic Dutch approach are universalist policies that apply to everybody. And I think they're good social reasons for doing it, the whole set of reasons. But so I said, let's combine them and have universalist policies with effort proportionate to need. Because in the end, the NHS is that. We don't all get the same treatment. The need is defined clinically. If you've got diabetes and peripheral vascular disease and cardiovascular disease and so on, you get more treatment than if you're sculling along a river at 80. And that's right. So we have a universal system with effort proportionate to need. I said, let's define need socially as well as clinically, like level of deprivation. Well, exactly as you said, we've been pursuing policies that increase those divisions. And it is possible to do it differently. They do it in the Nordic countries. They do it in the Netherlands. I went to, many years ago, a Dutch colleague came over to see what we were doing on health inequalities, and came with a couple of his colleagues, took notes, and then he went back and did a report on health inequalities in the Netherlands. And he invited me to the launch of it. And what struck me was that he had politicians from different political parties talking to each other in a civilized fashion. Nobody was being rude nobody said, oh, when you were in power or when you were in power. They were all talking about a national concern with health and inequalities in health and what they could do to make it better. I couldn't tell who was from which party. Now, I'm sure human nature is alive and living in the Netherlands. Look what's going on in the current election in Holland. But it was a very different approach. And I think that kind of social cohesion and the idea that flows from it of universalist policies is key to improving social conditions and hence to reducing health inequalities. How we get from here to there, well, that's more complicated.
Stay positive.
Of course.
Indeed, indeed. Very sadly, we've run out of time because I kind of think we could carry on asking questions much longer, but are you going to be able to stay for a few drinks afterwards? Well, not a few drinks maybe, but time, more importantly. That would be lovely because I'm sure people would... Aideen, you are staying, aren't you? yeah, because I haven't given you permission to go, so that's fine. So you're staying too. And I know Professor Carol Black will be here too if you would like to talk with her. So, first of all, I would like to thank particularly Professor Sir Michael and Dr. Aideen, as we call her in Centre for Ageing Better, for their fantastic presentation. So thank you very much. Before we close, I would like to say a special thank you to some organisations that have contributed to the State of Ageing report. So, and I know that we've got some representatives in the room. So the Race Equality Foundation, Manchester BME Network, University of Manchester, Aberdeen Financial Fairness Trust, University of Bristol and NatSan, and we're really grateful for the insights that they've contributed. And of course, we'd like to thank the GLA for hosting us here today at City Hall. We are in the new year going to be running a webinar to explore the incredibly rich data from the report in more depth, and we'll send everyone information about that. For me, a takeaway this evening has been it's so impactful listening to you both, and the huge responsibility that we have at the Centre for Ageing Better, I think all of us, for making hope possible rather than despair convincing, and going away and not being overwhelmed, because that's the other thing that happens, isn't it? You go, oh my gosh, the problem's so big, where do we start? But holding on to the fact that we can, step at a time, drop at a time, make a difference, and hold on to that hope. So that's my biggest takeaway. We've got to keep on keeping on. And so again, thank you to you both. And now I'd like to invite everyone to join us in the atrium. Is that just the area behind here, I believe? Is that right? Someone's going, yes, good, thank you. And hopefully see you there for more interesting conversations. So thank you again. Well done.